40 to 70% of the healthcare organizations that I work with have cut their quality budgets significantly. One of them dropped all the physicians participating in quality, but things are stalling. And they're stalling because people are stretched. They're stalling because we don't actually get to the front lines. We don't have time because we're too busy doing chart reviews. We're stalling because our leadership support fades away partway through the initiative, or leadership changes, and now the new leader has a different set of priorities. Hard-won data, the stuff that we work really hard to get, now has no one to act on it because there aren't enough people around. We've decreased our workforce. And the changes that should stick seem to dissolve back into old patterns. The gap is not our tools themselves, it's the translating between the leadership intent and the frontline reality. Leadership's deciding what we need to accomplish based on the operational goals and strategic plans. They've got star ratings to worry about, leapfrog grades, accreditation, board level accountability, and then the frontline is swamped. There is so much going on in a very, very small span of time and space that being overwhelmed at the end of a day is just the standard now. In the middle between those two is that messy middle, and it's that translation gap that we have to walk into. Because when leadership launches a project and it begins, if we don't, the quality improvement professionals do not adequately translate what the leadership wants to what the frontline needs, the frontline's going to disengage, and then we're not going to have an impact. And I don't know about you, I've been a part of enough of those projects that it is morally exhausting. I do this work because I want to see patient care improve. Instead, it might not do anything. And I'm putting all of this effort in. I was on a project very early on with one of our senior nurse leaders, part of the Patient Safety Leadership Fellowship through the American Hospital Association and the American Society of Healthcare Risk Management. And we realized that we could do the exact same heparin protocol project for the rest of our careers and never make a difference, because the house staff rotate every 1 to 2 weeks, the attendings rotate every 2 to 4 weeks, and everybody's rotating. And so every time somebody rotated, we had to restart the whole project again. It was so demoralizing. Why in the world would we keep doing it? Well, the answer is we couldn't, because we had other projects we ended up having to do.